If you have started your morning every day for the last several years by swallowing a small pill labeled Amlodipine, Folemti a Formonikaki, Losartan, or Lisinopril, I want to ask you a very direct question. How confident are you that you truly understand the chemical conversation that pill is having with your internal organs right at this very moment? I am not talking about the generic warning label on the bottle or the brief summary the pharmacist stapled to your bag. I mean a deep, functional understanding of how that compound is altering your heart, your vascular walls, and your kidneys. I am talking about knowing the exact conditions under which that medication could covertly shift from being your protector to becoming a source of medical complication. When I sit down with patients in my clinic, people who are highly educated, meticulous with their finances, and sharp as a tack, they almost always hesitate when I ask that question. That moment of silence is telling. It reveals a dangerous truth about modern medicine. Millions of Americans are living on what I call medical autopilot. They take powerful, systemic drugs with the same casualness they would use for a daily multivitamin. But make no mistake, amlodipine, losartan, and lisinopril are not vitamins. They are sophisticated, high-potency agents that fundamentally rewrite how your cardiovascular system operates. Taking them without understanding their unique fingerprints is like flying a plane without knowing what the gauges on the dashboard mean. It works fine until the weather changes, and in your body, the weather can change very quickly. My name is Dr. Carter. I have dedicated my career to closing the gap between the complex world of clinical medicine and the practical reality of your living room. This channel exists because a 10-minute doctor's appointment is rarely enough time to give you the tools you need to be truly safe. By the time this video concludes, you are going to possess a level of mastery over these 3 medications that will make you significantly more confident and far less likely to be blindsided by a preventable crisis. I want to start by telling you about a man named Robert. Robert was a 70-year-old retired structural engineer. He was the kind of man who kept his garage organised by tool size and never missed a scheduled maintenance appointment for his truck. He treated his health with the same engineering mindset. When his physician added amlodipine to his daily routine, Robert viewed it as just another line item in his maintenance log. He assumed that because it was for blood pressure, it functioned just like the others he had taken in the past. That one assumption led Robert down a path of fear and unnecessary restriction that lasted nearly a year. Within 4 months, Robert noticed that his ankles were becoming unrecognisable. By 4 in the afternoon, his legs felt like lead weights. He stopped going for his evening walks because his shoes felt 2 sizes too small. He eventually convinced himself that his heart was failing. He spent his nights staring at the ceiling, wondering how much time he had left before his circulation gave out entirely. The reality was far less grim, but because no one had explained the specific chemistry of his medication, Robert was suffering in a prison of his own assumptions. To understand why Robert was struggling, and why your experience might be different from your neighbours even if you take the same coloured pill, we have to look at the 3 doors of blood pressure management. Before we go into those details, I want to hear from you. Please take a moment to leave a comment with your name and the city you are watching from. I read through these comments personally because it helps me understand the community I am serving here. Now let us break down the science. The first thing you must realise is that while amlodipine, losartan, and lisinopril all share the same goal of lowering blood pressure, they achieve that goal through completely different biological pathways. Think of your blood pressure as a plumbing system in a large house. To lower the pressure in the pipes, you could turn down the main pump, you could widen the pipes themselves, or you could change the chemical signals that tell the pipes to constrict. Amlodipine belongs to a class of drugs known as calcium channel blockers. If we look at the smooth muscle cells that line your arteries, they require calcium to contract. Amlodipine acts like a microscopic gatekeeper. It blocks the calcium from entering those muscle cells, which forces the arterial walls to relax and widen. It is a direct physical intervention in the architecture of your blood vessels. When the vessels widen, blood flows with less resistance, and the pressure drops. Lisinopril, on the other hand, is an ACE inhibitor. It does not work on the muscles directly. It works on the chemistry. Your body produces an enzyme called angiotensin converting enzyme, or ACE. This enzyme creates a powerful substance that causes your blood vessels to tighten like a clenched fist. Lisinopril intercepts this process. By blocking that enzyme, It prevents the tightening from ever happening. It is a chemical strategy rather than a mechanical one. Then we have Losartan, which is an ARB or angiotensin receptor blocker. It operates in the same neighborhood as lisinopril, but through a different door. Even if your body produces the substance that causes constriction, Losartan sits on the receptors of your blood vessels like a protective shield. It prevents the tightening signal from ever being received. This distinction is not just academic. It is the reason why some people develop a persistent cough on one medication, but not another. It is the reason why some people experience swelling while others feel perfectly fine. When you understand which door your medication is using, you stop looking at your body's signals through a one-size-fits-all lens. In Robert's case, the amlodipine was doing exactly what it was designed to do. It was relaxing his arteries. However, amlodipine is famous for being much more effective at relaxing the arteries than it is at relaxing the veins. This created a hydraulic imbalance. More blood was flowing down into Robert's legs through the relaxed arteries than his veins could efficiently carry back up to his heart. This created a build-up of pressure in the tiny vessels near his ankles, which eventually pushed fluid out into the surrounding tissue. Robert was not experiencing heart failure. He was experiencing a predictable side effect of vascular relaxation. Once we identified this and adjusted his protocol, his life returned to normal within weeks. The name on your prescription bottle is more than just a label. It is a roadmap. It tells you exactly where the potential roadblocks are located. But we need to go deeper than just swelling. There are subtle signals and specific interactions, particularly involving your diet and other over-the-counter medications, that can turn these helpful drugs into a serious liability. Understanding the 3 doors is just the beginning. Next, we're going to look at the specific trap that catches people taking lisinopril and why a certain type of cough should never be ignored. Let us focus specifically on that swelling, because it is perhaps the most widely misunderstood side effect in the entire world of hypertension management. It affects a staggering number of people taking amlodipine, yet it is frequently misdiagnosed by patients themselves. I want to revisit Robert's situation because his reaction to the swelling is where the real danger lies. When Robert saw his ankles puffing over the top of his socks, his first instinct was to assume he was retaining water because he was drinking too much of it. He began to restrict his fluid intake. He thought that if he put less water in, less would leak out. This is a logical assumption, but in the context of a calcium channel blocker like amlodipine, it is a dangerous mistake. Here is the physiology of what's actually happening. Inside your body, your heart pumps blood into your arteries under high pressure. These arteries branch out into tiny vessels called capillaries. Once the oxygen is delivered to your tissues, the blood must then travel back up to the heart through your veins. Your veins, however, are a low-pressure system. They rely on the contraction of your leg muscles and tiny one-way valves to fight gravity and push that blood upward. When amlodipine does its job, it relaxes the smooth muscle in those small arteries very effectively. This allows a large volume of blood to rush into the lower extremities. But remember, amlodipine does not have that same relaxing effect on the veins. So you have a high volume inflow and a standard volume outflow. This creates a bottleneck at the level of the ankles. The pressure inside those tiny capillaries becomes so great that the watery part of your blood is literally squeezed through the vessel walls and into the surrounding tissue. This is not a salt problem. This is not a kidney problem. It is a hydraulic pressure problem. When Robert stopped drinking water, he became dehydrated, which actually made his blood thicker and harder to pump, while his blood pressure began to fluctuate wildly. There is another reaction I see often. People see the swelling and simply stop taking the medication without a word to their doctor. They feel relieved when the swelling goes down, but meanwhile their blood pressure is quietly climbing back into the danger zone. They have traded a visible nuisance for an invisible killer. If you are experiencing this, you must realize that you do not have to suffer in silence. There are several professional strategies we use to manage this. Sometimes, simply changing the time of day you take the medication can help. For others, we use a specific elevation protocol, where you raise your legs above the level of your heart for 20 minutes in the late afternoon to help gravity assist the veins. In many cases, adding a very low-dose second medication can actually counteract the way amlodipine affects the vessels, balancing the inflow and outflow. The takeaway is this. If your shoes are getting tight or your legs feel heavy by 4 p.m., do not diagnose yourself with heart failure on the internet. And certainly, do not stop your medication. This is a specific mechanical side effect that your doctor can often fix with a simple adjustment. Now we must move to a completely different side effect profile, one that belongs to the ACE inhibitor family, specifically lisinopril. This is the story of Martha. Martha was 68, a retired librarian and a passionate gardener. She had been taking lisinopril for about 6 months with excellent results. Her blood pressure was the best it had been in a decade. But then, around late April, she developed a dry, scratchy tickle in the back of her throat. Because it was spring in Virginia, Martha assumed it was pollen. She bought over-the-counter allergy pills. When those did not work, she bought a high-end air purifier for her bedroom. Then she began to think it was acid reflux, so she changed her diet and started taking antacids. She even went to an urgent care clinic, where she was prescribed a round of antibiotics for a suspected sinus infection. None of it worked. Martha's cough was not a sick cough. It was not productive, meaning she was not coughing anything up. It was simply a relentless, irritating sensation that became much worse the moment her head hit the pillow at night. By the time Martha came to see me, she was exhausted from lack of sleep and convinced she had something far more sinister, perhaps even lung cancer. When I looked at her medication list, the answer was staring us in the face. About 15 to 20% of people who take lisinopril will develop this specific dry cough. It happens because lisinopril prevents the breakdown of a substance in your lungs called bradykinin. When bradykinin builds up, it sensitizes the sensory nerves in your airway, leading to that constant tickle. The most frustrating part for patients like Martha is the timeline. This cough often does not start the day you take the first pill. It can wait 3 months, 6 months, or even a year to appear. Because of that delay, most people never make the connection to their blood pressure medication. Once we switched Martha from lisinopril to Losartan, which, as you remember from part 2, works on a different door of the same system, her cough vanished in less than 10 days. She didn't need antibiotics or air purifiers. She just needed a medication that didn't interfere with her lung chemistry. However, while the lisinopril cough is a nuisance, there is another side effect in this category that is a genuine medical emergency. I need you to listen very closely to this. There is a rare but life-threatening condition called angioedema. It is a sudden, severe swelling of the deep layers of the skin. If you are taking lisinopril and you notice your lips, your tongue, or the area around your eyes beginning to swell, you are not having a minor reaction. This is not something that a Benadryl will fix at home. This swelling can migrate to your throat and your airway in a matter of minutes. If you feel any fullness in your tongue or difficulty swallowing while on an ACE inhibitor, you do not call your doctor's office and wait for a callback. You call 911 or go to the nearest emergency room immediately. It is rare, but it is unpredictable, and it can happen even if you have been taking the medication safely for years. Knowing the difference between a nuisance like Martha's cough and an emergency like angioedema is the difference between being a frustrated patient and being a safe one. If you have ever experienced that weird, unexplained tickle while on lisinopril, tell me about it in the comments. How long did it take you to realise it was the medication? Your story might be the clue someone else needs to finally get a good night's sleep. Next, we are going to talk about Losartan and why your attempt to be heart healthy at the grocery store might actually be putting your heart's rhythm in jeopardy. Now let us turn our attention to Losartan and the class of drugs known as ARBs. For many, Losartan is the cleaner alternative to lisinopril because it rarely causes that nagging cough we just discussed. However, Losartan carries a hidden risk that is often triggered by the patient's own virtuous intentions. I call this the healthy food trap. I want you to meet James. James was a 72-year-old former high school principal who took his health very seriously. When his doctor told him he needed to lower his sodium intake to help his Losartan work better, James went to the grocery store and did exactly what the marketing told him to do. He bought a popular salt substitute, a product labelled as a heart-healthy alternative to table salt. For 3 months, James used this substitute liberally. He used it on his eggs, his grilled chicken, and his steamed vegetables. He also started making daily superfood smoothies with spinach, avocado, and coconut water. To James, he was being the perfect patient. But in reality, James was walking into a physiological ambush. The chemistry is simple, but dangerous. Both lisinopril and losartan tell your kidneys to hold on to potassium while they are excreting sodium. For most people on a standard diet, this is perfectly fine. But salt substitutes are not made of sodium chloride. They are almost entirely made of potassium chloride. By using that substitute on every meal and doubling down on high potassium smoothies, James was flooding his system with potassium while taking a medication that prevented his body from getting rid of the excess. This led to a condition called hyperkalemia. The danger of high potassium is that it is a silent actor. It does not make you cough, and it does not make your ankles swell. Instead, it interferes with the electrical signals that keep your heart beating in a regular rhythm. James started feeling what he described as heavy fatigue. He felt a strange fluttering in his chest that he dismissed as anxiety. He noticed his muscles felt weak, almost like he had the flu, but without the fever. It was only during a routine blood draw that his doctor discovered his potassium levels were in the danger zone, high enough to trigger a sudden cardiac arrest. The lesson here is not to avoid bananas or spinach. The lesson is about the concentration of potassium. If you are on losartan or lisinopril, you must be extremely cautious with salt substitutes and potassium supplements. Your heart-healthy choice at the grocery store needs to be vetted by your physician. This is why I tell my patients, do not make major shifts in your supplements or salt alternatives without a simple blood test to see how your kidneys are handling the load. We need to discuss a scenario that almost no one prepares for until it is too late. What happens to these medications when you get sick? I am talking about a common stomach bug, a bout of food poisoning, or even a particularly hot summer week where you are sweating more than usual and failing to keep up with your fluids. When you are dehydrated, the internal environment of your body changes. Your blood volume drops, and your kidneys have to work significantly harder to filter your blood with less fluid. In this state, a dose of lisinopril, or losartan, that was perfectly safe on a normal day can suddenly become toxic to your kidneys. There is a clinical term for this that every senior should know: the triple whammy. This happens when a patient takes three things together: an ACE inhibitor, or ARB, like lisinopril or losartan, a diuretic or water pill, and an over-the-counter anti-inflammatory, like ibuprofen or naproxen. Imagine a woman named Barbara. She's on losartan and a water pill for her blood pressure. One morning, she wakes up with a stiff, painful back, so she takes 2 Advil. That afternoon, she develops a mild stomach virus and cannot keep fluids down. Within 48 hours, Barbara could be in acute kidney failure. Why? Because the losartan relaxes the blood vessel, leaving the kidney. The ibuprofen constricts the blood vessel, entering the kidney. And the dehydration and diuretic have already reduced the total blood flow. The kidney is essentially starved of pressure and oxygen. This is why you need a sick day plan. You should ask your doctor today, if I get a fever or a stomach virus and cannot stay hydrated, should I temporarily stop my blood pressure medication? For many, the answer is yes, but that is a decision that must be coordinated with your healthcare provider. Never assume the rules of your medication stay the same when your body is in crisis. As we conclude, I want to address the most common minor symptom that actually leads to the most devastating outcomes: dizziness. That brief 2-second wobble you feel when you stand up from your favourite chair or get out of bed in the middle of the night to use the bathroom. Most people dismiss this as getting old or standing up too fast. But if you are on blood pressure medication, that dizziness is a signal that your pressure has dropped too low for your brain to receive adequate blood flow for those few seconds. In the medical world, we call this orthostatic hypotension. While the dizziness itself passes, the result of that dizziness is often a fall. And for a senior, a fall often leads to a hip fracture. The statistics on hip fractures in adults over 70 are sobering. It is a leading cause of a permanent decline in independence. The fix is often mechanical. I teach my patients the sit, wait, stand method. Do not bolt out of bed. Sit on the edge of the bed for 30 seconds. Flex your calf muscles to pump blood back toward your heart. Then stand up while holding onto a piece of furniture. Give your medication and your nervous system time to calibrate. If the dizziness persists, it is not a minor issue. It is a sign that your dosage may be too high or your hydration is inadequate. Finally, I want to change how you look at your blood pressure numbers. Your blood pressure is not a static number like your height. It is a moving target. It changes when you speak, when you drink coffee, when you are cold, or when you are stressed about the reading itself. Stop reacting to a single high reading with panic. Do not take an extra pill because you saw a 150 over 95 on a stressful Tuesday. And do not skip your pill because you saw a perfect 120 over 80 on Wednesday morning. The medication is what created that 120. I want you to use the rule of 5. Sit quietly for 5 minutes before taking your pressure. Take your pressure at the same time for 5 days in a row. Use that 5-day average to determine your true status. This is the mastery mindset. You are looking for patterns, not snapshots. If you have stayed with me until the end of this video, you are no longer a passive passenger in your own healthcare. You understand the 3 doors of Amlodipine, Lisinopril, and Losartan. You know how to spot the potassium ambush and how to avoid the triple whammy during a sick day. You are now the most important member of your medical team. If this deep dive has given you a sense of clarity you didn't have 20 minutes ago, please let me know by typing the number 9 in the comments. It lets me know that this level of detail is helpful to you. I am Dr. Carter, and this channel is here to ensure that you stay safe, stay informed, and stay in control of your health. Thank you for watching, and I will see you in the next video.